So a patient's tumor microenvironment can be incredibly complex, and often no two patients' TMEs can be the same. There are a complex mix of cell types, immunostimulatory and immunosuppressive, normal cells as well as tumor cells themselves, and stromal cells and fibroblasts. And so often it's a balance between these different cell types, and you've got immunostimulatory cell types, CD8 T cells, for example, or M1 macrophages. They can sort of create a cascade of a positive anti-tumor immune response where you have T cells that kill tumor cells. That results in tumor cells spilling open, those epitopes then being available extracellularly, and that can then create a sort of a virtuous circle where the immune response is amplified. But then on the other side, you've then got immunosuppressive cell types, things like M2 macrophages or regulatory T cells, and even the tumor cells themselves. So they try and take that sort of circle the other way and try and drive things like T cell exclusion. So T cells kind of come into contact with tumor cells directly, or other immunosuppressive patterns. So I guess as a broad term, the TME describes that sort of ongoing conflict in each patient's tumor, and therapeutic modulation really aims to identify or address particular cell types, either depleting. Some approaches can be to deplete certain immunosuppressive cell types, deplete Tregs, for example, or even reprogram certain cells from an immunosuppressive to an immunostimulatory state for sort of M2 to M1 macrophage repolarization. Other approaches are more broader, targeting certain checkpoints that may be expressed by many cell types. And that's what's been probably the most effective with anti-PD-1, anti-CTLA-4 treatments, but they're probably the most complex to understand because multiple cell types have been affected just through one drug type.